How are we doing? But Jennifer, are we there?
Yeah, it started.
Okay. Well, then welcome everyone who's here. I'm Jane Burns, and I'm the director of the Kawasaki Disease Research Center, and we're delighted to have you joining us for the 16th annual Kawasaki Disease Parent Symposium. I'm going to go through some rules of the road here. We are delighted to have Lucia Acosta joining us again as our Spanish interpreter. And to access the Spanish interpretation, there is a button you can press here that if you click, it says interpretation. You want to click that. And then you have choices of language and you select Spanish. And then if you click this button, you will get rid of the English portion of the audio. And so that may make it easier to hear the translation. And for questions, we're going to have two 30-minute sessions today. So please use the Q&A function. It's not going to be in the chat, it's in the Q&A. And then those questions will be distributed to various of our panelists to answer during those sessions. So please put all your questions there and we'll be happy to answer those. This is the group of panelists that we have today, and I'll be introducing them as we go along. But a special thanks at this moment to Lucia Acosta, our Spanish interpreter. We really appreciate her help for all of our Spanish speaking participants. This is the agenda for today. We're going to have a morning session with back-to-back talks with a brief interlude as we change screens and stop sharing and reshare. And then we'll have a 30-minute Q&A session, a short break there for people to get their cup of coffee and come back. And then a second session of talks, followed by another 30-minute Q&A session. So we really hope that we can get to everybody's questions and we can make this an interactive as much as possible type of presentation. So I'm going to give a brief update on Kawasaki disease at Rady Children's Hospital and at other children's hospitals across the country. This is a graph, a bar graph, showing the number of patients at Rady Children's Hospital, which is our pediatric hospital here in San Diego. We're a single large tertiary care hospital that serves a catchment area of about 4.5 million people. And in average years, we see between 80 to 100 new Kawasaki disease patients. And obviously, as we've spoken about before, during the pandemic, with all of the mitigation strategies for the pandemic, our numbers fell by about 50% for Kawasaki disease, and that was mostly in school-age children. And now we're working our way back. Obviously, 2024 doesn't represent the entire year, and we're coming up on our big KD season, which begins in November and then builds into the winter. So those are our numbers. And at this time, we're beginning to get back to a more normal distribution of patients. Usually we say that 85% of Kawasaki disease patients, at least in the United States and in Japan, are under the age of 5 years. And here you can see we're at 70%. So we're working our way back up to that number. During the pandemic, interestingly, the number of infants didn't change. And you can see that we still have in the orange color here quite a large proportion, almost 20% of our patients are these under 1 year children who are, of course, very, very vulnerable to the cardiac problems. This is a graph of a new database to which we have access thanks to Chisato Shimizu in our team, who went through the onerous training procedures to be able to access this data. And this is what we call an administrative database of all the freestanding children's hospitals spread across the United States. It's rather interesting to see that those children's hospitals are not evenly distributed across our country. And Shoko Yamazaki, who's a visiting scholar with us from Japan, put together this map so you could see what this looks like. And we can now access data about Kawasaki disease from these centers, how they were treated, and maybe a little bit about their outcome. Your child may have been cared for at one of the hospital systems shown here. Rady Children's Hospital in San Diego is highlighted here in red. And you can see that as a single hospital, we're probably the single largest hospital for KD admissions each year. This was 2023. In Atlanta, there's a healthcare system with many hospitals, and that's similarly true of Texas. But we are just one single hospital with about 70 new patients in 2023 as we build back up after the pandemic. So I wanted to touch on some work that you're going to be hearing about in more detail from Charles Copeland, our research associate working with our climate team. But I just wanted to review some of the issues that bear on the question that we all have in mind and is foremost for all of us, which is what causes Kawasaki disease. That is something that everybody wants to know, and I've spent the last 40 years of my life thinking about. And I just wanted to share with you some facts about Kawasaki disease so that any theory that you may encounter, whether it's on social media or in the newspaper or wherever, that you just keep in mind some of the facts of what we know about Kawasaki disease. So we have been collaborating with the Japanese team, and Japan remains at this point the country of highest incidence in the world. And we know that it was a new disease after World War II. And obviously in Japan and in the region of Asia, many things changed at the cessation of the war. One thing that happened to Japan was there was a huge influx of about 150,000 Americans who came in and occupied Japan for a period of time. There was also the repatriation of Japanese who had conquered and were living in many regions of China, Korea, the Philippines, and other parts of Asia, Taiwan also. So everybody came back into Japan. There was a big change. And beginning in the 1950s, we begin to hear sporadic reports of patients that meet the case definition of Kawasaki disease in Japan. But what I really wanted to share with you was that there were these big epidemics in Japan that happened in the late 1970s and 80s. And then there was a period of somewhat stable baseline. So this could look like COVID or any situation where you have the introduction of a new trigger into a population that's highly genetically susceptible. And then after the big outbreaks where you sort of use up the susceptible people, you now have a stable baseline. But now there's something very dramatic that begins to happen in Japan, and that is continuing to the present day. This downturn here is the COVID situation. But as we look at this curve, there really isn't any infectious disease model that we have that can explain 1,000 more children presenting with Kawasaki disease every year. And yet the infants in this darker these are less than 6-month-olds in this dark line here, are actually pretty stable across this time period, obviously increasing a little bit, but this is only maybe 1.5-fold increase. So somehow we have to explain these facts about Kawasaki disease with whatever theory or hypothesis we want to entertain. So the first one would be that this was a new disease in Japan after World War II. Now, was it new or old in the West? That's a debate that continues. But clearly it was new in Japan and probably in many countries in Asia, including India, the Philippines, Taiwan. And the greater than threefold rise for school-age children is really not consistent with any single infectious disease model that would be person-to-person spread as the mode of transmission. So we have to come up with another thought about how that might be happening. And then the fact that masking and social distancing during COVID was associated with a 35% reduction of KD cases in Japan and a 50% reduction here. Clearly, there's something that children are breathing in. I think you can't walk away from that conclusion. And there's something that they're breathing in that does trigger the disease only in genetically susceptible children, because of course we're all breathing the same air. So another aspect of the work that we're doing here is trying to understand some of the variability that our clinical team, so that's Audrey Tremolay and Kirsten Doomer and myself, some of the variability that we see in Kawasaki disease patients. They don't all look exactly alike, and there's some subtle variations in how they present and the clinical signs that they have. So Hao Wang, who works with our group as a research associate, simply asked the computer, is Kawasaki disease a single disease? And what Hao came up with, and this was published last year, is in fact that the computer saw 4 different groups of Kawasaki disease patients. And these groups had different features to a certain extent, different laboratory manifestations, and importantly, different risk for either being resistant to IVIG, those children whose fever persists or who need additional treatment, and whether or not you got aneurysms. Those outcomes were not evenly distributed across these groups. So this is making us think harder about the idea that Kawasaki disease is maybe Kawasaki syndrome, and we need to get towards a deeper understanding of these clusters. So could there be potentially different triggers for different groups of children who may have slightly different genetic susceptibilities, so different genetic patterns in small ways that make them manifest the disease in different ways and put them at risk for some of the complications in a different way. So we've been working on the cause of Kawasaki disease for half a century, our group and groups across the world. And I think it's a much more complicated situation than we probably first appreciated. So I will leave that there with that thought percolating for you. And in terms of KD information that we think is reliable, the KD Foundation website is a great place to go. And the KD Foundation is sponsoring this webinar and the funds needed to do this symposium. So a huge shout out to them. They're a wonderful organization, and I really encourage you to check out their website. And thank you for continuing to support us in the 16th year. We also have a website here for our KD Research Center and information for parents that you may find helpful. So here's some QR codes for you. And this is the talented group of people that I have the privilege to be the cheerleader for, and many different aspects of research going on here. And you're going to hear from some of these individuals in the presentations to follow. So next, we're going to turn to Koichi Miyata, who is a visiting scholar from Japan. He's going to share his slides, and we're going to switch to specifically honing in on the issues of the cardiac problems from
Okay, good morning. My name is Koichi Miyata. I'm a pediatric cardiologist in Japan and currently visiting research scholar at the Kawasaki Disease Research Center, UCSD. Today, I'm going to talk about how we can prevent coronary artery aneurysms. First, I'd like to explain what the Z-score is. A Z-score represents how much larger a coronary artery diameter is compared to the average diameter for a child of the same size. When we evaluate the coronary artery based on echocardiograms, we have to adjust the measurement of the internal diameter of the coronary artery based on the size of the patient. How big the artery should be depends on the size of the child. So we put the internal diameter into an equation that normalized for body surface area, which is a combination of the height and weight of the patient. The bell-shaped curve shows the distribution, and Z-score 0 is average diameter, and most people have coronary artery Z-score between -2 and +2 and are considered a normal coronary artery. Z-score between +2 and 2.5 is considered dilated, and over 2.5 is considered an aneurysm. We did a study comparing outcomes of KD patients treated within the first 10 days after fever onset. These patients received IVIG according to standard protocol in the US and Japan. Even though the patients were treated appropriately with standard therapy of IVIG within 10 days of fever onset, 5 to 6% developed large or giant coronary artery aneurysms, and roughly a quarter to a third developed small to medium-sized aneurysms. Well, how can we do a better job to prevent aneurysms? The American Heart Association scientific statement was published in 2017, and this statement suggests adding additional treatment to reduce inflammation to protect the coronary arteries in patients believed to be at high risk for aneurysms. However, no guidance was provided on how to identify patients believed to be at high risk for aneurysms, and no additional treatment specifically recommended. So who is at highest risk for aneurysms? Previous studies have demonstrated that the most significant risk factor for subsequent coronary artery aneurysms is Z-score greater than 2 on the initial echocardiogram, either right coronary artery or the left coronary artery. In Kawasaki disease, what's happening in the child's body? We can think of inflammation like the fire inside the body. Two important molecules are fuels for fire. One is TNF alpha, and the other is interleukin 1, IL-1. So next question is, what is the best way to put out the fire of inflammation? We have a toolbox of 3 different medications in addition to the standard therapy of IVIG. First, all KD children should receive IVIG, and then options in the toolbox are corticosteroids, infliximab that blocks TNF alpha, and anakinra that blocks IL-1. We published the first report last year showing that infliximab, a TNF-alpha blockade, for intensification of primary therapy is associated with a greater likelihood of aneurysm resolution in patients with aneurysms at the time of diagnosis, who are the highest risk population. Dr. Kirsten Dumer from our center and Dr. Samuel Dominguez from Children's Hospital, Denver, Colorado, studied initial echo results in infants with KD less than 6 months of age, diagnosed within the first 10 days after fever onset. In this study, there were 73 infants less than 6 months of age at 2 centers, and 59 patients, 80% of them, had abnormal first echocardiograms, shown here in this pie chart. At 2 centers, 98% received infliximab that blocks TNF-alpha, and the majority of them received infliximab within 24 hours of IVIG infusion. In this slide, you can see the trajectory of the left anterior descending artery and right coronary artery. Many of the patients once got worse and then were treated with IVIG and infliximab. At the time of 1 year, all patients had a Z-score under 3.0, and most of them had normalized below the black line of Z-score under 2.0. This infliximab treatment seems to be an effective way to protect coronary arteries. So our current treatment protocol at Rady Children's Hospital San Diego is to treat with IVIG and aspirin as standard therapy and add infliximab for patients with Z-score greater than 2.0 at the time of diagnosis on the initial echocardiograms. So we think the answer is yes, we can prevent long-term coronary artery damage. Corticosteroids or other approaches may also be effective. Our approach using IVIG plus infliximab is working pretty well for the most vulnerable and the highest risk population. That concludes my presentation. Thank you very much for your attention.
Thank you, Koichi. That was a great presentation. And continuing on in the vein of cardiology, we're going to switch now to Dr. Kirsten Dumer, our pediatric cardiologist KD team member. Many of you have met Kirsten in our clinic, and she's going to be talking to us about exercise.
Okay, thank you for the introduction, and thank you to everyone for being here this morning. Today, I'm going to speak about exercise and Kawasaki disease. Specifically, are there any limitations? Physical activity is very important in our child's lives and in adults' lives. Not only does it help with our physical strength and muscle mass, but it also serves to decrease anxiety, improve sleep, boost immunity, and improve the quality of life. And being physically active as a way of life can decrease some illnesses that can actually add to heart disease in adulthood, like obesity, type 2 diabetes, and hypertension. For patients that follow us in clinic, you'll hear us talk about endothelial cells, and those are the cells that line the inside of the vessels. And they get damaged in the acute inflammatory phase and are very important for kind of being a doorway to damage in the vessel walls. And exercise actually improves endothelial cell function, which is very important in our Kawasaki patients. The CDC recommends participating in at least 60 minutes of moderate to vigorous, intense physical activity every day. Moderate physical activity can look like a lot of different things, and it's not necessarily doing the same activity for 60 minutes in a row, but rather it's the accumulative time spent on a daily basis being physically active. So anything from washing a car to shoveling snow to playing basketball, raking leaves, pushing a stroller, all of these things, in addition to the sports we think about, are considered physical activity. And again, the recommendation is for children to have 60 minutes a day of being active. So I was trying to think of some of the ways in which patients with Kawasaki disease might be hesitant, or the reasons why. And I think that there's kind of a cycle that happens, and it probably relates to comments either from providers or from family members, or even heard kind of secondhand when the children are recovering. And so they get this very bad illness that's, frightening in appearance. They're very inflamed. A lot of the patients are very sick. And in that recovery phase, there probably is a notion of, oh, you should take it easy. Maybe don't go back to your sport yet. Maybe sit out at gym a little bit. And in the early phase, that creates a fear of exercise. And then the patients don't know how much or how little to do. And this just leads into a spiral where then it's easier for parents and grandparents to just restrict or say, oh, it's probably safer not to do things. And then that leads to a relatively sedentary lifestyle, which is a really big risk factor for these other disease processes in adulthood, like obesity and high blood pressure and type 2 diabetes. And so I think it's just kind of a cycle that happens, and probably the stages of that are laid kind of early in the recovery phase. So like Dr. Miata had mentioned, there is a published statement from the American Heart Association. And a statement is expert opinions. So it's the best opinion of the most experienced peoples. And this is a table that includes all the patients that have had Kawasaki disease. So even if you've never had coronary involvement, if you've only had transient dilation, if you've had small aneurysms, medium aneurysms, or large or giant aneurysms. And on this table, it's about long-term follow-up. There's a section called physical activity counseling. And at every single category, whether you've never had coronary artery changes, all the way up to if you've had giant aneurysms, the recommendation is for promotion of physical activity at every visit. So promoting activity, it's a good thing at every visit. The only time that you'll see the words restrict is in the categories of moderate to larger aneurysms. And then it gets very specific to say that the only patients who are restricted are patients who are on medicines, specifically 2 medicines for antiplatelet, like aspirin and Plavix together, or patients that are on blood thinners, like apixaban or other direct oral anticoagulants, or warfarin or Lovenox. Those patients are restricted for contact sports or sports that risk bodily collision, but they are not restricted for all activities. We still want to promote them to be active, but we want them to choose activities that are safe based on the medicines that they're on. And then there's mention of self-limiting in patients with residual aneurysms, and that simply means that these children should not be coerced or pressured into performing or overexerting. So if the patient feels like they're having difficulty on that particular day, maybe they didn't drink enough water, maybe they're having symptoms, they should be allowed to rest, and we should not push them through it. So in exercise, we ask a lot of our coronary vessels, and here is a picture of the outside of the heart sitting in a chest. And I'm sure that many of you have seen us either draw pictures or bring in the heart model, but We have right coronary artery that arises from the rightward aspect of the aorta and then brings blood flow and nutrients to the heart muscle. And then we have a left coronary artery arising from the leftward aspect of the aorta that then branches into an anterior descending artery and a circumflex artery that wraps around the back of the heart. These are the arteries that we talk about when we talk about what we see on the echocardiogram and whether or not there are aneurysms. And here on the right is a depiction of the various kind of arteries and kind of an understanding or assessment of blood flow through them. So if you have a straight tube and the walls are not damaged, the blood flow easily travels through this vessel, which is all uniform in size, and the blood flow shouldn't have any trouble getting to the heart muscle. In an artery that's been inflamed, those endothelial cells that line the inside of the vessels allow in inflammation and cells that can do damage. And you'll see that the inside of the vessel gets very irregular. And this creates sometimes some trouble of the blood flow going through it, which is why all of our patients are initially on aspirin. We say that it slicks the platelets so that they're better, the blood flow is better able to go through these inflamed vessels. And in our patients who have aneurysms or these outpouchings of the vessels, the velocity kind of slows down in that area because there's a bigger size vessel, and there can be kind of different eddies of blood flow, and that's when patients are at the biggest risks of thrombus, which is why patients with aneurysms are treated with either two kinds of antiplatelet medicine like aspirin and Plavix, or systemic anticoagulation like apixaban, Lovenox, or warfarin. In some centers, we don't use warfarin. So we worry about the blood flow getting through these diseased vessels, which is why we use the medications. And if there are times when clot forms in the vessel and the blood flow can't get through the blood vessel, it leaves the heart muscle vulnerable, which means that that area of the heart does not get enough blood flow. And that's called ischemia, when the part of the heart muscle does not get enough blood flow. This is also what happens when adults get heart attacks. There isn't enough blood flow going to the heart muscle. So ischemia can be seen on an EKG. We do EKGs almost on every visit when patients come to us, but we also do EKGs during our exercise testing. The EKG signs of ischemia are much less sensitive than actually looking at the heart muscle squeezing when we're asking so much of it with exercise. So there are recommendations about how often children should undergo ischemia testing in that same table, in that same statement. And every center has a different approach to how they evaluate this. In our center, we use stress echocardiograms. So that's when the children often are on the bicycle, and we increase the difficulty frequently throughout until their heart rates get as high as we can get their heart rates. And then they jump off the bicycle and they lay onto a table, and we do an ultrasound and we watch all the parts of the heart squeezing, and we want to see it being uniform. We don't want to see any part of the heart muscle lagging or not squeezing as much, because that would indicate not enough blood flow to that segment of the heart. Other centers use MRI stress perfusion, which is a little bit of a bigger undertaking. We are starting an MRI stress perfusion program, and so some of our patients may end up getting this test as well. It might be slightly more sensitive, we're not sure. And obviously, if we see problems on ischemia testing, then that does require us to restrict patients from further exercise as we do more evaluations. So the medicines patients are on can impact the exercise. And then if the ischemia testing is abnormal, that can impact exercise. But otherwise, exercise is really recommended and promoted. And these are taken from that statement. So this is what is published out there in the expert opinion. And we're going to go through each category of patients in terms of never having had coronary problems to large aneurysms. And I'm going to show you what is written. So for patients who have never had coronary artery changes, there is no indication for ischemia testing, and it is reasonable to let them participate without restriction or precautions at any time. So that's kind of the simple end of the spectrum. Then we get in the middle here with the small and medium aneurysms. And for the small aneurysms, which are defined by these z-scores between plus 2.5 and plus 5, whether or not they have persisted in follow-up or regressed in follow-up, the recommendation is for ischemia testing infrequently. So every 2 to 5 years, depending on if they're still present or not. And again, it says it is reasonable to provide physical activity counseling at every visit with no restrictions and no precautions. So these patients are free to participate in whatever they want to participate, regardless of whether or not they have residual small aneurysms and they're on aspirin. So these are the categories where there are caveats to physical activity. So not saying they can't do it, saying that they have to make choices that are safer for them. So for patients with medium aneurysms of z-scores of plus 5 to plus 10, whether they are persistent or regressed, there are recommendations for ischemia testing. So every 1 to 2 years if they're still present, or every 2 to 5 years if they've gotten better and improved. And the physical activity recommendation is that it's reasonable to provide physical activity counseling at every visit without restrictions or precautions. Participation in competitive sports or high intensity activities should be guided by the results from the ischemia testing, which is why when we do the ischemia testing and we are happy that it's normal, it's because it allows us to let you participate in whatever you would like to do at a competitive level. For patients who are still on aspirin and Plavix, it does say that activities involving a risk of bodily contact, trauma, or injury should be restricted or modified. So we think about football. We do think about sometimes soccer, which is becoming very physical and at higher ages and higher competitive levels is some people considered a contact sport or bodily injury risk. So we kind of have to go through a conversation with the patient about what's important to them, what they're wanting to participate in, and then with kind of forthright counseling about, okay, here's what the risk profile looks like. But we certainly want patients to be active. So there are a number of different sports and activities that are very safe for patients. And then similarly, but probably on a bit of a more significant level, are these patients with giant aneurysms. So patients that have persistent giant aneurysms are the patients that have the most caveats for physical activity. And that's because we really should be doing ischemia testing every 6 months to 12 months. So that sounds pretty frequent, but again, we want to make sure that the blood flow is going through that diseased area of the vessel without any problems during exercise. And then the same counseling is true here about how it's important to promote physical activity, but if you want to participate in competitive or high intensity activities, that we have to really do the ischemia testing on a regular basis, pretty frequently. And that if you are on anticoagulation therapy like apixaban or Lovenox, or in some centers warfarin, then those risks of bodily contact and injury and high velocity injury, those sports are probably not the best for you because you can have bleeding internally when you're on those sorts of medicines. So despite these publications, I just wanted to say that unfortunately, there is a hesitancy out there in the world community. Now, this is obviously a small survey of 28 pediatric cardiologists, but there's a hesitancy to come to a level of comfort with recommending physical activity in some of our patients with residual aneurysms. And so knowing this and knowing how important physical activity is in our patients, I want to just speak for a minute on failure to counsel. So when doctors and care providers who are seeing our Kawasaki patients all around the world, when we don't talk about exercise and activity, it leads families and the patients to feel uncertain about it. And then that leads to kind of the fallback mechanism of, well, it's safer not to do it, which is completely understandable. But we really don't want our children not participating. We want them to be active. So I want to just empower everybody on the call, including our patients, ask if the doctor forgets to discuss exercise and activity, ask at every visit, and ask about ways, if there are certain activities that can be modified a little bit, ask about ways to reduce the risk, like whether it's a helmet or a Kevlar shield or different supervision or environments, and really talk about the importance of self-limitation. So help us and help your doctors if you don't follow with us to talk about this, because it's very important. So exercise in Kawasaki disease, when should it be limited? The answer is really rarely. And it's only limited for patients who are on Plavix and aspirin, and for patients who are on systemic anticoagulation like apixaban or other DOACs or Lovenox or warfarin. And even then, it's only limited for contact sports or sports that risk high velocity bodily injury. And then, of course, very rarely, if the ischemia testing is abnormal, those patients are restricted until there's a further evaluation and discussion. So overall, exercise is good. We want our patients to live healthy, physically active lives, and would love to partner with you in making that happen. So thank you very much.
Thank you, Kirsten. We're all sitting here thinking that we should be out exercising instead of sitting here on this Saturday morning, but hopefully this afternoon you'll all get out and do some exercise. I'm going to share my screen now and share with you some new insights about the molecular studies that we're doing and partnering with many collaborators. And over here, oops, oh dear, not that one. Here we go. You notice I'm the least skilled of all our presenters in getting my screen up. Anyway, there we go. So new molecular insights. This requires a little bit of understanding of basic biology. So I don't want to stress anybody out with this small biology lesson here, but it's pretty straightforward. We're going to be talking about DNA, which is basically the code that determines everything that happens in your body and therefore in your life. And this is within every cell in your body. And understanding Kawasaki disease susceptibility and aneurysm formation, the answer to why your child got Kawasaki disease is going to lie in their DNA. And if you were followed at a center where they don't do genetic counseling to your child when they're getting ready to be discharged from care, that probably needs to happen and would be a good idea, because it's important for them to understand that in their DNA, they have a pattern for susceptibility. And it's also important for them to understand as they get older and perhaps want to start their own family, that they understand that there's a chance that they can transmit this pattern to the next generation. Okay, so moving on in our biology lesson here, we've got DNA, and this DNA gets changed, we call it transcription, into a second molecule called RNA. And we think about RNA as a window into what cells are thinking. So cells are making this transition here and creating these molecules when they're receiving signals that tell them that this should happen. So it's a window into what cells are thinking. This set of molecules then, the RNA, gets translated into proteins. And proteins are really the business end of the story here. So understanding what cells are making and why is this final step in the pathway. We've found it very instructive to actually look at this stage at what the cells are thinking. And there's some very robust technology now for doing that. So we're going to talk a little bit about the research that involves these 3 steps along the way. So let's talk about race and ethnicity. At Rady Children's Hospital, 36% of our patients are Hispanic. And Kawasaki disease is not an equal opportunity disease, but it certainly can affect all children of all races. And it has now been diagnosed worldwide on every continent. Maybe not Antarctica. I don't think we see it in penguins, but in children, it can affect all races and all ethnicities. We have a very small African-American population here in San Diego, but in other centers such as Atlanta or Washington, D.C., they may have a much larger proportion of African-American children affected with Kawasaki disease. So because of our special representation of Hispanic children here in Kawasaki disease, we've really focused a lot of our research on this group. And in this chart, color-coded here, you can see the experience in terms of aneurysms in red of our patients who are self-declared Asian descent, Hispanic descent, and most of these patients in our community are from Mexico or Central America. And then the people who self-identify as European descent. These are white people. And you can see the difference in the risk of aneurysms across these different groups. The highest risk for aneurysms is among our Asian population, which argues that there's a genetic predisposition for aneurysms that is not evenly distributed across these groups. But our Hispanic population seems to be at increased risk compared to our European descent population. However, despite this increased risk, there is no Hispanic genetic study that has ever been done in Kawasaki disease. So children of Hispanic origin have actually been systematically excluded from genetic studies. And this is, in the past, largely been due to the fact that there hasn't been the availability of control groups. So what do we mean by control groups? When we do these comparisons of the genetic code, we're looking at our children who are affected. That's our children with Kawasaki disease. And then we're comparing those children to a group of children who are matched for age and sex and any other variables that we can think of, and race and ethnicity would be one of them. And then we compare those 2 groups. Now, for genetic studies, what we need for Hispanic genetic studies are large control groups of people who have self-declared Hispanic ethnicity, but who never had Kawasaki disease. And until recently, that level of information and the genotype, so the DNA sequence of those kinds of people, was not previously available, and that hampered these studies, whereas the necessary control groups were available for European descent individuals. And so all of the studies were really biased. It should also be said that studies of African American children were affected in the same way by the lack of control groups. One of the ways in which we do our analysis in genetics is also to look at the passage of DNA, that's the fundamental genetic material, from the parents to the child, in this case, a child who had no effect on the heart from their Kawasaki disease, or in this case, a child who did have effects on the heart. And we're pretty sure that all of this story is really determined by the genetics that were passed down from the parents. Now, this is a complex genetic pattern. So this mother, this father, neither of them had Kawasaki disease in childhood because each one of them only carries a portion of the pattern that's necessary. It's a complicated pattern. And every time you make a new human being, you roll those genetic dice, and these children inherited the pattern that made them susceptible to Kawasaki disease. So that's why in our clinic, your family has been invited to give a mouthwash sample from our parents and a mouthwash or a blood sample from the affected child. And then we are able to do this analysis of looking at the kinds of genetic patterns that are being transmitted from the parents to the child who develops Kawasaki disease. Well, our exciting news to report, we had a brief update on this last year, but now we can say that with an amazing partnership with the Macklin Foundation, and without philanthropy, this project would never, ever have happened. So a huge shout out to the Gordon and Marilyn Macklin Foundation, who donated a sufficient number of funds that we were then able to go to Illumina, the company that makes these machines, these sequencing machines. And they were so impressed with this donation that they were willing to make a similar donation that allowed us to complete whole genome sequencing as well as RNA sequencing. Remember back to the biology lesson at the beginning. So we were able to sequence both the DNA and the RNA, and that sequencing has now been completed. And we have created a database that will be released and made available to the entire world so that everyone can participate in the study of the genetics underlying Kawasaki disease. What this has created, I will say, is really a flood of information, a flood of genetic and genomic data that we are working hard to begin to harvest the information that's hidden there. And Ji-Hoon Kim, who was here at UCSD and working with our team for a decade, has now moved to Yale University, but is continuing to be the leader for our genetic genomic studies. And he's assisted in that by many of the people shown here, some notable collaborations within our own group, but also other collaborators at Yale University, Melissa Jimrick, who is an expert in a certain kind of DNA analysis here at UCSD. We're very lucky to have her here. A collaborator who is really the lead for genetic studies in Japan, and a new collaboration with a wonderful group of researchers at Princeton Precision Health, who have created a lot of the tools, the computer tools, for analyzing DNA and RNA sequence. But because they're at Princeton, where they don't actually have a medical school, these are PhD researchers who don't have patients, they're very excited about having the availability of real data from real patients linked to their outcomes. Did they develop aneurysms? Were they resistant to IVIG? And we're very excited about this new collaboration with a talented group of scientists at Princeton. So it turns out that the genetics of our Hispanic children is very, very complicated. And if you think for a minute about what genetics really represents, it represents the movement of human populations across continents, not only countries, but across oceans. And in this schematic made by Dr. Kim, our genetics leader, you can see that part of the contribution of genes to the Hispanic population came across the land bridge almost 100,000 years ago with migrations that came from Asia. So there are Asian genes in here. And then there were explorers from Spain and the old world that came to the new world, and they brought their genes with them. And then there was a contribution of African genes. Some of those actually came up here through Spain, and there was migration into parts of South America. So there's a really complex mixture of genes in this Hispanic population that we will need to sort out. I love this slide because it's very colorful. This is not the kind of statistical or genetic work that I know how to do, but that's why we have partnership with all kinds of talented people who understand these things. And what you're looking at here is what we call chromosome painting. And what it shows is the local ancestry. So in the last slide, I showed you how there can be contributions to our Hispanic population from so many different parts of the world. And here in the color coding box down here, you can see that in these 4 individuals, so these are 4 people, 4 of our Kawasaki patients, and we're looking at one single chromosome, chromosome number 19. And we're looking at the parts of the chromosome that actually have their derivation from European descent, from East Asian, what we call Amerindian, which are Native American populations, African populations. And you can see that across these 4 individuals, the complexity of their DNA and the control group that we need to use for this part of the chromosome, this part of the chromosome, this part is different. And so there's a huge challenge, but not an insurmountable one, in analyzing the genetics of our Hispanic population. So what do we think we're going to learn from this study that we are just now embarking on? We're going to be able to look at the complex genetic pattern that determines Kawasaki disease susceptibility. And we think that there's a different pattern for susceptibility in different races and ethnicities. So we know that the Japanese population, for example, are highly susceptible because they have a very large number of patients. So 1 in every 60 children in Japan gets Kawasaki disease. That's very different than what we see among our mixed ethnic or Hispanic European descent populations here in the United States. So clearly the genetic pattern determines susceptibility, and we're going to be able to learn about what that pattern is from the work that is ongoing now. In addition, there's a genetic pattern on top of susceptibility that predisposes a subset of children to aneurysm formation. Now, before we had IVIG treatment, and perhaps regrettably, I'm old enough that I took care of patients and remember that time period very well. And at that time, 1 in 4 children, regardless of their genetic background, would develop aneurysms. So that was true for Asian descent children, that was true in Japan, it was true in the United States, and it was true in Western Europe and the UK. So the genetic pattern that predisposes to aneurysm formation, that is on top of the pattern that predisposes to susceptibility, that pattern is likely, based on our observations in the pre-IVIG era, to be a conserved pattern that will be the same or at least similar across all races and ethnicities. And we certainly hope to unravel that mystery as well. Turning now to our newest project, we're looking at a collaboration with the group at Cornell, who began to mine the sequences of RNA that were floating free in our bloodstream. We call this cell-free RNA, or cfRNA. And when people discovered that these strands of RNA were floating around in our bloodstream, the first question was, why are they there? And what was discovered was that when a tissue, here's a heart, when a tissue is injured, the injured cells are breaking down and they are nearby blood vessels. All of these tissues have to have a rich blood supply. And when cells in that tissue break down, they release all of their insides into the bloodstream. And part of that contribution are fragments of RNA that enter the bloodstream. This is a liver, and in similar ways, when the liver is injured and those cells die, all of those injured parts will flow into the bloodstream, and that will include these RNA fragments. So there are two ways of looking at RNA. One is that you can take the whole blood and you can look at the RNA that's actually contained in the cells that are in the bloodstream. So these are white blood cells, even red blood cells contain RNA. And you can burst these cells and look at their content. This is a different approach. In this approach, we get rid of the cells. We spin them out in a centrifuge, we remove them, and we just take the plasma and we look at the RNA molecules that are there that really tell us about tissue of injury. And so here you see us spinning out the cells. They're in the bottom of the tube. We're not going to work with those. We're going to analyze the cell-free RNA in this fraction of the blood. And that is RNA that can then be sequenced. And when we sequence it, we can actually, almost using a dictionary, look up that sequence and map it back to what tissue was injured, what cells were injured that released those RNA molecules. So Ewan DeVlamick and Connor Loy, who just did his PhD thesis on this topic, are joining us in looking at all of these potential applications for cell-free RNA in Kawasaki disease. We're very excited about the possibility for diagnosing Kawasaki disease, because it turns out that the tissue of injury in KD is very different from adenovirus or some of the other look-alike or look-similar diseases. So there's really a signature of tissue injury that we think is going to turn out to be a wonderful diagnostic tool for Kawasaki disease. And so we're actively pursuing that idea. We want to understand the tissue injury that may be there in the different subgroups. Remember, we talked about at the beginning of the morning the idea that there are different outcomes and perhaps different genetic susceptibilities, perhaps different flavors of Kawasaki disease patients. And maybe we can understand those differences more profoundly if we look at the cell-free RNA. Also, response to therapies. When your child gets steroids or your child gets infliximab or even just IVIG, we don't have very good tools for understanding all the changes that happen in the body, and cell-free RNA is going to be a window on that. We're also interested in this tool to be able to predict coronary artery outcomes, aneurysms or not, and the prediction of IVIG resistance. Again, getting back to this signature of the cell-free RNA that's floating in the bloodstream. And maybe when the patient walks in the door of the emergency room, there is information right then and there in their bloodstream that is going to allow us to make these kinds of predictions, which would clearly influence the way we treat the patients and lead us towards a precision medicine approach to individualize care for our Kawasaki disease children. So with that, a big thank you to all the people who really get this work done. And I think it's time now for our question and answer period. So I will stop sharing. And Audrey is going to lead us in our Q&A.
Thank you, Dr. Burns and Dr. Miata and Dr. Doomer for your presentations. We now have about 25 minutes to go through some of the questions that have been posed. So let me go ahead and pull that up. For Dr. Burns, there was a question about the DNA that we've collected. So we have someone whose child we've followed. It's an African-American patient, and the grandmother's writing about the DNA test kit. She said, I received it from you. We sent it in, but we weren't sure about the results and was curious about how to figure out some information about the DNA that we collect from our patients and how to get those results.
So I'm very happy to have the opportunity to explain how we do these genetic studies in a little more detail. First of all, it's all preserving privacy. So the DNA is linked to a number. There are no names involved. There are no dates of birth. There are no protected health information that are linked to those DNA samples. And then when we do the analysis, we do an analysis of all the parents and all the children, and these are groups. So we don't actually look at any individuals because the analysis has to have power from looking at groups of both parents and groups of children and how the DNA gets passed down from all the mothers and all the fathers to the affected children. So we will never have individual results that we give back to families, except in one very specific case. And that is, we feel that we have a moral responsibility if we're working with DNA. Obviously, we see the sequence of individuals. And if we were to come across a known mutation associated with a known disease that has real health implications, then we feel morally obligated to let that family, or let that individual rather, know. And the way that works is I would be notified by the laboratory that such and such a number sample contains such and such a mutation that's well characterized, that has a definite health effect. In my computer, I can reconnect that number with a name. I can contact that individual and explain the finding. I will tell you that in the last 3,500 samples that we processed, that has happened twice. And it happened to be two separate mothers who had a mutation for a blood clotting disorder that would be important for them to know. They had to have that assessed in an official CLIA certified genetic testing laboratory, because we're a research laboratory. We're not certified to give out those kinds of results, but they did have it tested and it was confirmed, and they were very grateful for that information. But you really don't want to hear from me because it would only be in the case that you are carrying a known mutation for something that has nothing to do with Kawasaki disease, but we just happened across it.
So families are also wondering how to participate in the genetic studies. So maybe we can also, you can clarify who we'd like to get enrolled and how that can happen if they qualify.
Right. So as everyone knows, we exist on donated philanthropy, right? And research grants. So funding is always an issue for us. And at this point in time, we don't have the funding or the bandwidth in terms of our team to solicit DNA samples from remote families unless your child has aneurysms. And we're really trying to enrich our DNA pool for aneurysm patients. That's obviously a smaller subset of the total. So if you have a child who has aneurysms and your family would like to participate, we can do that by sending a mouthwash kit to you. Or if your child is an infant, we have swabs that parents can do in the home. And we can send you the swab kit and the mouthwash kit for the parents. And the way you want to contact us is through kdgenetics@ucsd.edu. And if you reach out to our research center, you can find our contact information if you didn't get that email address, and we'll be happy to discuss sending a kit to you.
Thank you. So Dr. Miata spoke about treatment and focusing on the role of infliximab. There was a question about a family whose child was treated with steroids and anakinra, and I'll take this one. It says, I know that it's not as common to treat with steroids. Is there a reason? And so I'll just say that it's not common for us to treat with steroids. I think the use of steroids in combination with IVIG is continued to be used around the world for children with aneurysms and with treatment-resistant KD. I would say that we particularly in San Diego and many sites that work with us have been using infliximab instead of steroids because of the biological data that we have that supports the use of infliximab. And in terms of what we know about the pathophysiology about the disease. But there's really been no head-to-head trial that's been done, which is really the standard, that's taken a population of children with either the heart disease or with resistance to IVIG to figure out if infliximab or steroids, which one of those is better when combined with IVIG. We'd love to do that study, but it hasn't been funded, and we're trying to figure out ways to get that done. So it really is very regional in terms of what is used to treat your children. But we wanted to certainly have the opportunity to share the latest information in regards to infliximab and how well it works in KD patients with you. So there's some questions here also about the immune system and whether when you've got KD, does it predispose you to any other diseases? Is it an autoimmune disease? Does it allow you to develop any hyperautoimmune diseases in that realm? I don't know, Dr. Burns, if you want to go ahead and just answer that in particular.
Sure. One of the problems with Kawasaki disease is that it's its own beast. So it is specifically not an autoimmune disease. It is not apparently or obviously an infectious disease. And it is more in the category of disease that we call autoreactive. However, the other members of that autoreactive group are usually children born with severe genetic mutations that make them have inflammation from almost the time of birth onward. So our disease doesn't really fit very well with that group of diseases either. And I think that's been part of the problem with funding as well for this disease, is that we're not in any of those categories. So even though you'll read many chapters that start off with Kawasaki disease as an autoimmune disease, it is not an autoimmune disease. So the disease itself is not that, and there's no evidence at this point in time that it predisposes to autoimmunity later in life. However, we are doing what we call our adult KD study with questionnaires that you can sign up for when you're 15 or older, and then receive every 2 years. And we'll be hearing more about that in the second half of the presentation this morning. And we're trying to study, are there long-term outcome issues that haven't been uncovered or haven't been recognized? And right now the answer is no. We're not seeing anything in the realm of autoimmunity that is obviously linked to Kawasaki disease. It doesn't mean that someone who had Kawasaki disease in childhood couldn't develop an autoimmune disease later in life, but we have no reason to believe that the Kawasaki disease had anything to do with that.
Thank you. So there is a question that has to do with the question of heart rate. During acute Kawasaki disease, this parent noted that their 3-year-old child's heart rate was very high. And so I think this is an important point, because it is one of the things that Dr. Burns and I use when we go to see a patient where Kawasaki disease is being considered. And that it happens because the heart muscle itself is inflamed in Kawasaki disease patients. And so the heart is not working as efficiently, and it does cause the heart rate to be higher. So the mom here was wondering why that was happening, and I think it's important for families to understand that that is part of the acute Kawasaki disease presentation as well. So there were a number of questions that relate to exercise stress testing. Dr. Burns and I can sort of together answer some of these questions. Dr. Doomer had to head off as a resident cardiologist, but we're used to seeing these patients as well. So in terms of the age, so Dr. Burns, just a little bit about what age we start doing the exercise testing, and who should really have it done. So why aren't like these stress tests performed until age 12 is one particular family is asking.
So every center is going to be different in terms of expertise and the available modalities. In order to do an exercise test in a young child who can't really cooperate with the protocol of getting on a stationary bike and riding it, people resort to using what we call chemical stress. And we tend not to do that at Rady Children's Hospital. And we wait until the child is actually old enough to get on our small stationary bike and mature enough to be able to pedal hard. We really need to get the heart rate up around 200. And then we have them jump off the bike and immediately do the echo. So it's something that requires an older child who can cooperate and do that testing. It is possible, and I know lots of other centers across the United States do chemical stress. It requires general anesthesia. It's a much more complicated procedure. It involves an IV and giving the drugs that, in a sense, create exercise.
I think
They
Dr. Burns,
stimulate the heart, and they have to be in a controlled situation where that's safe. So we don't do that at Rady Children's Hospital, but many centers do. So we wait until the child's old enough to be able to cooperate with a safe, easy, no radiation, no chemicals, no IV type of stress test.
Yeah, and there are some questions here about who should get the stress testing done. As Dr. Doomer pointed out with the 2017 AHA statement, that it's for children that have had coronary artery abnormalities. So there's a family here asking if they should get a stress test done. They don't clarify their child's history of coronary artery abnormalities, but they're asking about getting stress tests done if the child's going to participate in contact sports. And I think the answer for that is that the stress testing for Kawasaki disease is based on the coronary artery abnormalities. So it really depends on what the abnormalities were. Like, for example, in our patients, if you never had coronary artery abnormalities, we would not be doing a stress test in your child. So let's see here. There's other questions about environmental factors. There's a family who is expressing concern about environmental allergies. And is there any increased prevalence in allergies after Kawasaki disease? So if you want to answer that, Dr. Burns.
So studies have been done in Asian populations where, for whatever genetic reason, allergies are very prevalent and very common. And there's a difference of opinion in the literature. So some studies from Taiwan have associated, yes, with allergies and Kawasaki disease being genetically linked, and other studies from Japan and other places have not found that association. I think the bottom line is whether they're linked or not, a good allergist has great options and therapies for handling environmental allergies, and exercise is super important for the heart. So it would be important to pursue exercise and get a good allergist who can help you control the medications of whatever pollen is happening out on the soccer field. It's still really important to get exercise for your child.
Yeah. So there's some questions about the timing of treatment that I'll take. So one family says that they had a child who had KD when they were 5, and the child is now 9, so it's 4 years later. And they had aneurysms. It's currently on aspirin. And so is there any role for anti-inflammatory therapy now? For example, is there any role for infliximab at this point? So our general rule of thumb is that these anti-inflammatory therapies are really useful during the acute period of Kawasaki disease. And sometimes we even do them a week or two later. But at some point, I think we use the phrase, the horse is out of the barn. And it's that now what we're dealing with long-term, especially in this child who's 4 years out, what we're dealing with is what's happening in the vessel wall in terms of making sure that there's no blood clot that forms. And that's where that role of the medications that Dr. Doomer talked about with the direct oral anticoagulants that I'll go into a little bit more, as well as aspirin, have a role. So the long-term use or late use of these anti-inflammatory therapies in KD as of now is not standard practice. And for us, it would be more when the child presents initially. There's also a question about the likelihood of aneurysms happening later. So if your child had a normal baseline echo, but then what's going to happen at the 2-week or the 2-month follow-up? So the majority of the abnormalities of the coronary arteries, over 80% of them present in the first week to 10 days. So that is why, because it's not everybody that's seen in, that is why the recommendation is to have a follow-up 1 to 2 weeks after discharge from the hospital. And that's especially important for our younger patients. So if you have a child who's, for example, less than 6 months of age, it can be pretty sneaky, and they can have a normal echo in the hospital, and then they can develop aneurysms between the time of discharge and being seen in the outpatient setting. That is much less common for older children, although we can see it. But I would say that certainly if you have normal echoes in the hospital and then at that 2-week follow-up, it is unlikely that anything will ever develop, and certainly not, 2 months, a year later. That would not be the normal course of what happens with Kawasaki disease. So there was a question about the cell-free RNA, Dr. Burns, and how long that lasts in the bloodstream, and sort of, when can you see these signals, and that sort of science. If you could address that, that'd be great.
That's a really great question. Thank you for a very sophisticated understanding of what we usually think of as a very vulnerable molecule. So those of us who have spent our lives working with RNA go to great lengths to protect the RNA, but these are RNA molecules that are coming out of live cells where we've actually burst the cell. And when we burst the cell, it turns out that we burst and contribute into that fluid lots of enzymes or molecules whose job it is to actually degrade or break down the RNA. So single-stranded RNA, as it flows around in the circulation, probably is protected in some way with some membrane, with some proteins that are binding to it, but it is extremely stable. And we can reproducibly get the same results week after week after week from the same individual. And this kind of testing has been done by Ewan Devlamic's lab at Cornell to really be sure that this is a stable signal that we can get from plasma. And it appears that it is, and it is a new kid on the block. This is a new understanding. And no one had really, people had looked at cell-free DNA, which they thought maybe would be more stable. Cell-free RNA is a new story, and it's being marketed or touted or advertised as a liquid biopsy. Again, because of its ability to tell us about cell injury. And cancer doctors are really jumping all over this. And we are too. But great question. Thank you.
So we spoke about the genetics of Kawasaki disease this morning. There's a question about genetic counseling. I'll just say that for us, we take the opportunity to really educate our families that KD is a genetically linked disorder. From the very start, from their first visit, because that's really where we're approaching our families about collecting DNA as part of the studies. We go a little bit more in depth about things when kids are graduating from our clinic, which for most kids tends to be between the ages of 15 to 18. But there was a question, Dr. Burns, about how likely it is if you yourself had KD that your children would develop Kawasaki disease. If you could kind of get to that point a little bit.
Yeah, so that's why we're doing our long-term adult KD study. For 20 years, a health questionnaire. This may take people through the period where they would be starting a family and have young children. And the answer is it's not 0%. So we're talking about the risk of transmitting your genetic pattern because you had KD to your offspring. It is not 0%. It is not 100%. It's probably low, but we certainly have parent-child pairs in our clinic. It certainly happens. And what we hope to be able to calculate is the heritable risk from the studies that we're doing. But no one has the answer to your question right now. Not the Japanese, not the Chinese, not the anybody's. Yeah, it's a great question.
And there's a question about returning to school. So Kawasaki disease is not contagious. And IVIG is a whole lot of great antibodies that help us all fight inflammation, which is how it works in Kawasaki disease, as well as even some regularly circulating infections. So there's a question about whether how IVIG, if it helps and it protects our patients, or does it leave them immune suppressed? And I think it's really important for our families to know that neither KD nor IVIG are immunosuppressive. In fact, we've heard anecdotally from our families that when their kids, especially if their child had KD in like a preschool age, when our kids are sick every 4 to 6 weeks, that things are a little bit better and that the children are getting less ill frequently because of that protection that they have. So nothing to really worry about there. The next question I wanted to get to has to do with any link between KD and high cholesterol, and if that should impact in terms of how parents see either what the kids can eat or physical activity limitations at all.
Happy to field that.
Yeah, you could go ahead and field that.
Okay. So we think about heart health in 2 ways. On the one hand, your child had Kawasaki disease, and we can't undo that. And whether there's some microscopic changes in the heart or in the blood vessels, that's over and done with. On the other hand, there's the kind of heart disease that all of us are developing a little bit of as we age and as we pass through life on this planet. And that's atherosclerosis, okay? And for atherosclerosis, there are specific risk factors. How you metabolize the fats in your diet reflected in your lipid panel, cholesterol, is one of those modifiable risk factors. Hypertension, obesity, exercise, diet, these are all contributors to adult type heart disease. And they're modifiable, they're addressable, they're knowable, and they're potentially fixable. So we do cholesterol screening in our Kawasaki disease clinic at the 1-year visit. At that time, the body has returned to its normal baseline. And how you handle the fats in your diet is really related to genetics. So we want to do 2 things. We want to identify children who have inherited a not great way of handling fats in their diet and therefore have a high LDL, is what we call the bad cholesterol. They've inherited that from someone. It didn't just happen. It came from either the mother or the father. So in that situation, we want the parents to get their lipids checked because we want you to have a long and healthy life to take care of your children. So there's that aspect. But for the child, we want to make you aware of their predisposition to a not great way of handling fats in the diet, because it is likely that you, the parent, are the one who does the shopping at the supermarket and prepares the food. And therefore, we want you to be aware that there should be a shift towards healthier foods. And again, the American Heart Association website has tons of information. Google heart healthy diet and you'll get a million suggestions for what that looks like. And we want to empower you, the parent, with that information. And that's why we do cholesterol testing in our children. We also test for a molecule called lipoprotein little a, LP little a. And again, that's another potent genetic risk factor. It's inherited from one or both parents. And that is also a predisposer for atherosclerotic adult type heart disease. And we would want you to know if you have those that risk factor in your family, so you can again take steps to mitigate that.
Thank you, Dr. Burns, and thank you to all our speakers in the first part of this morning session. We're going to go ahead and take a 15-minute break, and then we will be back at 10:45 Pacific Standard Time, and I'll lead us off with discussing the recent International Kawasaki Disease Symposium. So we look forward to seeing you guys back in about 15 minutes. Thank you.
And I think that also we can type some answers to questions that we didn't get to in this session, and there is another 30-minute session at the end. So we'll save some of these, but welcome more questions as we go on. But we will type some answers back to folks. Thanks.
Thank you. See you guys shortly. All right, welcome back, everybody. We're going to get started on the second half of our symposium here. We've been trying to feverishly answer some questions in the chat, and I will do my best to also try and address a few questions and throw those into my talk as well. And as Dr. Burns pointed out, we will also have another 30-minute session starting at 11:30 a.m. Pacific Standard Time to go over additional questions. All right, so I'm Dr. Audrey Tremolay. I'm the Associate Director of our Kawasaki Disease Research Center, and I have the privilege of working with all these amazing people that are on the line with you today. And my task is to cover 3.5 days of content in 15 minutes. So put on your seatbelts. This is the 14th International Kawasaki Disease Symposium, which we affectionately abbreviate IKDS, which was held in Montreal, Canada, August 26th through 29th. So just a couple of months ago. And I was the co-president of that meeting. It was 3 years in the making from the last IKDS. I was handed the baton, and it was an incredible honor to have the opportunity to collaborate globally with folks that are really invested in Kawasaki disease, whether they are families, affected patients, foundations that are involved in KD, research scientists, as well as clinicians from around the globe. So I'd like to just share some of what we learned. What I'd like to start out with is to let you know that there's now a website that hopefully will last in perpetuity. It's called ikds.org. And it's really meant to be hopefully an umbrella to where to find things about Kawasaki disease. So we've it's still in the making. It's really brand new, but there's a way to go on there, get on the listserv, so that when we do newsletters, you'll get it, and send us information and ideas as well. Just to give you a snapshot, one of the first things we did was to get guidelines from around the globe. So you may be somewhere, and there's been questions about the guidelines and differences between different guidelines. So we've gone ahead and published guidelines from around the globe. It's just a snapshot of what we got. It's also a site where we have different foundations where hopefully families can land when the child's been diagnosed with KD and find the parent group in their area as well. So we had delegates from all over the globe. You can see we had 269 folks that were able to join us, and you can see a swath and distribution here. We were lucky to be to have representatives from 6 of the 7 continents, and to really engage in a very lively conversation. Debate happened. There was discussion. There was arguments and counterpoints, all of which is important for growth. So I wanted just to share some of the highlights, and we were graced by Subura Kawasaki's presence with us. This is Dr. Kawasaki, one of his daughters, that joined us for the meeting. Really poignant and important since Dr. Kawasaki's passing, since the last meeting that we had. And Dr. Brian McCrindle here from Toronto Sick Kids gave a lovely memorial lectureship in his honor. And I think one of the take-home points is this: the global collaborations that we're already doing and that need to be strengthened. So I want to just be able to highlight for you what's going on in that particular space moving forward. But I also wanted you to see a few photos of Dr. Kawasaki in his youth when he was giving some lectures later on in life. Some lovely drawings from his original manuscript with the description of the first 50 patients in 1967, which I think was an artistic labor of love for him, drawing out fever curves and everything in his patients. So really, KD is a global issue and disease, as we all know, but I also wanted you to know what's being done and what are the global scientific KD collaborations. And there's many across the globe, even in regions of the world like in Africa where we know less. In the Arab nations, there's Kawarabi. There's a group in South Africa, another group in Kenya that have been very involved, but it's really around the globe. And many of you that are on with us today that may be taking care of KD patients may already be involved in some of these registries. But I think the more that we have folks from around the globe involved in these global collaborations, the more information we'll learn. So I encourage those of you that take care of KD patients to try to seek out what your opportunity is local. So we've got folks that I lead a network in Latin America. There's the International KD Registry that focuses on the cardiovascular illnesses, not to mention all that goes on in Asia, Australia, New Zealand, as well as throughout Europe. So it's interesting to understand the prevalence of Kawasaki disease. So there are some parts of the world where the prevalence is going up, and there are others where it has been stable. Here in the US, we've actually had some stability, and we continue at Rady Children's to see anywhere between 70 to up to 100 kids a year. Pre-pandemic, we were seeing an excess of 100, and those numbers are climbing. But there are parts of the world where the prevalence and incidence are really increasing. Not so much in the US, but a couple places here. So Australia, you can see here that they had a 3.5 annual increase in KD over the last 25 years. And then in India, we spoke about last year about the dip that happened from COVID, in part possibly from having reduced exposure to some environmental triggers, but those numbers are kind of creeping up and climbing up. And so there are parts of the world where the numbers are increasing, whether that's increased observation and really people understanding the disease and being able to diagnose it, or whether there's actually increased prevalence is hard to tell in some parts of the globe. But I will say that the data that's not here is from Japan, which there is an increasing amount of KD there, even with a falling birth rate. And Japan has for decades known exactly what Kawasaki disease is. So there really is an argument for, in certain parts of the globe, having increased prevalence. So we took some real specific time during IKDS to try to address worldwide gaps in KD care. And we had several panels from leaders across the globe, again, across the multiple continents that we had, talking about whether it was diagnosis or whether it was treatment, but really just to allow people the opportunity to share what the gaps were in their regions. So is the gap that, you can't even have, you don't even have access to IVIG, or that you diagnosed the child, you were able to get IVIG, but you're having trouble getting an echo. And so different of the groups that I mentioned and showed in the couple slides ago, went ahead and did some surveying before the meeting. And so this is some work from the group from Arab nations, Kawarabi. And their questions had to do with quality according to urban setting, based on whether you were in a large city, a mid-sized city, or remote. And you can just see here that it was fair to poor in terms of your access to care as you were in a smaller city or in more of a rural area. And that's of course maybe obvious to most of us, but I think just really just saying that and re-emphasizing that, and just reminding people that there's still issues of access to care. In the Latin American network that I'm pleased to see some of our collaborators and some of our families that have been involved online with us today, so bienvenidos. We did a survey of our Latin American network we had 15 countries, 61 responses, and I think to me, this was one of the most striking findings was that timely diagnosis and treatment of KD was only there for 43% of our patients. So there's still issues to be uncovered about how to diagnose patients early and then how to treat them appropriately in a timely fashion, because it's only then that we can prevent the coronary artery abnormalities. So I wanted to just highlight a few things. We've talked a little bit already about treatment and some of the genetic work that's been done. And Dr. Burns talked about the cell-free RNA that's also was presented at IKDS. But there really is a power for AI. And the clinical decision support tools are being developed in many fields, including Kawasaki disease. So I wanted to highlight some of the work by Cedric Manlio. Excuse me here. And there we go. So as part of the International KD Registry, he took over, collected over 1,000 data points from over 1,000 KD patients that were enrolled in IKDR. And from there, he developed machine learning algorithms to try to diagnose or predict response to therapy. And what I'm showing you here is in terms of diagnosis, you see this clustering that happens. So some of these groups are KD, and one of these groups is KD and others are not, but you can see sort of how these things are grouping. You put all the data into the computer, and you just ask the computer, do these children have Kawasaki disease, or what else do they have? And it groups them by particular groups. So he has taken this and is working currently on trying to figure out, taking it from this algorithm into packaging it for the electronic medical health record, and really having it integrated. And I think this last piece is where we're at with a lot of AI. There's been a lot of publications in different diseases, including Kawasaki disease, and I'll show you another example from our center next. But it's really getting it out of the computer and out of the hand of the developers and the bioinformaticians like Cedric Manlio and his team, and really getting it to the provider and to the end user. And this is where a lot of work is being done, and he's doing this space within the electronic health record. Our team too is involved in clinical decision support tools. We're blessed to have the funding from the Gordon and Marilyn Macklin Foundation to support this. And this work has been really led by a couple of bioinformaticians and that we collaborate with, Dr. Shamim Namadi, and a doctoral student that was in his group, Jonathan Lamb. And I've shown this before, but I wanted to share it again because we've made some important steps. So this is our clinical decision support tool where the clinician will put in the clinical presentation of the child and then some very basic labs that are done around the globe to diagnose KD. And then at the bottom is a prediction. You can punch that button and it'll tell you a prediction of how likely it is this patient has KD. And we're really working now of taking this, again, like I mentioned with Cedric's work, from the computer to the clinician. So we've got a few studies going on in our emergency room, but probably the lead one that we're very grateful to our funders for has to do with putting this tool into the hands of the emergency department and into our emergency room doctor's hands to understand how it impacts the flow. Did getting this back, so we're going to be taking a group of ER docs and half of them get the tool and half of them don't, but they're all taking care of the patients. And so does having this tool help them in diagnosing KD? Does it make things run faster? Do the kids get admitted faster? Does it somehow negatively impact work? So sometimes you get back a result that you weren't expecting, and now you're ordering all these other tests and all this other imaging. So we're going to be able to do that. And we're very excited about the clinical application, and then eventually being able to put this into a format that clinicians can use and out there in a way that is already being used. So there's other physicians go and use several platforms online at particular location, like something called UpToDate that clinicians use very commonly. And our hope is to be able to get this decision support tools and others integrated and into the hands of the end user. All right, so another big highlight happened about therapy. We've already talked about the treatment stuff that we talked about with infliximab. But I wanted to highlight the direct oral anticoagulants that Dr. Doomer spoke to. And this was a very quick slide, hopefully mostly color oriented, where we've talked about options for anticoagulation for children with giant aneurysms. This is warfarin. There's low molecular weight heparin, and there's the direct oral anticoagulants. Now, these last group, known as the DOACs, abbreviated that way, are really what's being used across adult medications. And as pediatricians, we find frequently, actually, I would say probably all the time, that the majority of what we treat our kids with really lags behind what's being done in adults. And in some cases, that's appropriate because studies have to be done. In other cases, it may be because folks are not sure about how to test this medication in children. But I'm happy to say that there's been an early study that was done with some Kawasaki patients that really showed the DOACs to be safe in our aneurysm patients. So you can see here that while warfarin, it is given orally, but otherwise it's hard to follow the, you have to do a lot of blood checks, and it's hard to get it within the right range. It's actually a range of when the medicine needs to be at, and it's only in range not even 2/3 of the time in our Kawasaki patients. And if your child's on antibiotics, the levels can get really messed up. So a lot of us have been using low molecular weight heparin early on in our patients and trying to get them never use warfarin and get them on low molecular weight heparin, but that requires an injection. You still have some blood monitoring to do, although not as frequent as warfarin, but you do have to inject it. So that can be tough, especially in a toddler. So where we're moving towards is in some patients with low molecular weight heparin, after some time transitioning to the direct oral anticoagulants. And maybe there will be a time when that's where we can go immediately. But there's a lot of benefits there in terms of the predictability of the dosing, less monitoring, really not affected by food or medications, and it is oral as compared to low molecular weight heparin. So that's on the horizon, and we are very excited about the work that's happening in this space, as it really could be very important for our families' lifestyles. So in the last few moments that I have here with you, I wanted to touch upon something that I think is important to all of us that have had patients or family members, or even if you yourself are an adult now that had KD as a child, the transition of care. And we're very lucky to be joined in just a little bit by Bradley Phelps, who is a KD patient and survivor. And so transition of care is a really important piece, and it cannot be overemphasized. As a pediatrician, if I do a great job in diagnosing a patient, getting them to treatment earlier, but they still have coronary artery aneurysms, they'll need lifelong follow-up in many cases by an adult cardiologist. But if we don't communicate to our families and our patients that this is a lifelong disease, then I have 2 teenagers. We all know how that goes. You know, life goes on, you don't feel it, nothing's wrong with you, you're okay. You may forget to take the aspirin or the medicines that you were given because I'm okay. So while we don't want to stress our families out, and as Dr. Doomer said, we want to make sure that everybody knows when they can get exercise, that we're not creating an obesity epidemic in our KD patients. It's also balanced with making sure that those that need to be followed up understand their disease and understand the severity of it. And this is really important. We had a lot of discussions about this. So if you have a child with KD or are a KD survivor, and you know that you're going to need long-term follow-up, you need to know who that is. And it behooves us as providers to educate our teenagers about their disease, what it is, what to be afraid of, what not to be afraid of, what to look out for. So this was a lot of discussion. And this really led us to a very important piece of the meeting. So the patient perspective, which we're going to get to today, is frankly the part, and maybe the only part, that you'll remember from today. And I am not offended by that, because I think it's very impactful to hear from our patients. And we did just that at IKDS. I did that during my transition of care meeting. I had someone who was at the meeting who was a KD survivor with aneurysms, decided not to take her medicine, and eventually had a real severe effect. And I asked her to come up to the podium and share her story. And I still think that's probably what people will remember from IKDS long-term. But patients are really at the center of this whole discussion. So this is our group. It still gives me chills to look at this. I was just so proud to be in the room with all these amazing patient advocates, parents, KD adult patients, scientists, clinicians. Here we are, all raising our hands to really honor Dr. Kawasaki, which was how he would always end every IKDS, with his arms up and celebrating. So we are just thrilled to be there. This is our amazing team that I'm blessed to work with every single day. You'll be hearing from many of them. So with that, I will stop sharing. And I will go ahead and introduce Dr. Charles Copeland, who is going to talk to us about the new insights from environmental epidemiology. I know, Charles, you joined us last year to talk about the climate, but you've got some new things to share with us, so I will hand it over to you. Thank you.
Okay, hello. Thank you all for being here. I'll be talking about some of the new insights we're getting from studying the environmental associations with Kawasaki disease. So I'll briefly talk about why we study the environment at all. As many of you know, the cause of Kawasaki disease remains unknown, and a I just had a interruption. Okay. Is this coming through for folks?
Yep, we
Yes,
see that
we
well.
got it
Thank
now.
you.
Okay, great. Okay, so yeah, so getting closer to the cause, understanding the trigger of Kawasaki disease could have many potential benefits. Diagnosis is one, I think, that'll be on many people's minds here in the audience. There are many avenues towards getting closer to the trigger, the cause of Kawasaki disease, very worthwhile studies from genetics and immunology. But we think that studying the environmental associations is also a very worthwhile pursuit. And we do have evidence that environmental factors play a role. So what we do, we take information from the epidemiology of Kawasaki disease, the where, the when, the who, the how many, from the case record of incidents, and we compare that and we make associations with environmental factors related to the time and location of these cases. We then take these associations, and our aim is to use that to try to narrow down the list of possible causes and identify which clues we have are likely to be true or false. So one thing that's really useful when we're thinking about Kawasaki disease and the environment is this phenomenon we see from the epidemiology, which is that we see Kawasaki disease tending to occur in clusters around the same time or similar location. If Kawasaki disease was something that was very random, if cases were not connected to each other, incidents would be a bit more spread out across time. What we see instead in many locations around the world is that we have a short time period, a few days, when we see many cases coming into our hospitals, and then stretches of time that we might call low periods, where you have less KD than you would otherwise expect. So this graph on the right is showing the San Diego example. For many years, the cases per day in these little black dots. And what the blue line is indicating is what we define for San Diego as a cluster of high Kawasaki disease incidents, which for San Diego would be 5 or more patients within a 7-day period. And what we see is that the occurrence of these clusters, these blue vertical lines, is a lot more common than you would expect if cases were not connected or if they just happened randomly. What this suggests, especially because we see this similar trend in many regions, is that something is happening in the environment across the entire region, affecting potentially many children and many patients, and that it comes at the same time and then leaves. So a lot of our work has been studying Japan, and I'll talk a bit about why we focus so much on this country. For one, doing these kind of environmental associations works best if you have really large numbers of cases. That helps us get closer to proving environmental effects. Japan has a really large population and the world's highest rate of Kawasaki disease, and doctors there have taken extensive effort to collect hospital data from the entire country for many decades. And because of this careful work from collaborators internationally, such as Dr. Nakamura and many others, we have information about the where, the when, and other information such as age for more than 400,000 cases. And that gives us an entire record, showing here in the bottom right, the increasing incidence of Kawasaki disease over many decades. And we can use this to then look for environmental trends affecting Japan across different regions of Japan and different years. We'll talk a bit about why we study the wind in particular. There have been past studies that have found evidence for a relationship between Kawasaki disease and wind patterns. The Kawasaki disease story could be explained by theoretical KD causing trigger particles blowing on the wind and entering through the nose and mouth, triggering the immune system. And when you think about an entire region, such as San Diego County, seeing a few days when there's many cases, you could think about that in terms of the wind blowing these particles across an entire region. and then a shift in the wind possibly leads to a time period when you have a low number of cases. So there is a bit of a match with the epidemiological evidence. Now, with a theory such as the wind, there are a variety of different potential triggers we could think about in terms of what is blowing on the wind. Some researchers are thinking about a virus, and there is evidence that some viruses can survive blowing on the wind, traveling across very long distances. Another theory that has been brought up is a fungal trigger agent. And another one that we're thinking about is air pollution and whether that interacts with the immune system, particularly thinking about heavy metals. But to sort out all of these different potential sub-theories related to the wind, we need a really good understanding of which specific wind patterns are related to this disease. So we try to answer basic questions such as what the wind looks like when there are many cases, what the wind looks like when there are relatively few cases, and whether changes in the wind can explain why some years have more cases than others. So I'll talk a bit about what we do, the science behind modeling the wind, how we get the best possible estimates, how do we characterize the wind relative to KD cases in this epidemiological work. So the starting point for our wind modeling efforts is a collection of global weather records, data coming from weather station, coming from satellite measurements, many different sources around the world. And what is done with this, these are put into these supercomputer weather models, so very similar to the very powerful computers that you use to predict what the weather is going to look like 10 days in the future. But instead of predicting the future, we take all of this past data and use it to run these models on the past to try to fill in the gaps between weather stations, places where there might not have been records, to get what we call weather reanalysis data, which is a really high accurate estimate for past weather data around the entire globe for every hour going back many decades. And what we take from that in particular is what does the wind look like in these past models, which are a very good estimate of what the actual wind looked like on these past dates. And this picture on the bottom right is just showing an example where there are little arrows showing what the wind looked like on this past date, August 2012. And so we have a really good snapshot of what the wind looked like for every day over these past records of KD cases we're trying to use to study these environmental associations. So now I'll explain what we do with this wind data. For every day that we observe Kawasaki disease, what we really want to know is what was the origin of the air that patients are breathing. So if someone is breathing in air in Tokyo and we see them getting Kawasaki disease, we want to know where those air particles are likely to have come from. To answer that, we use the same software that environmental scientists use to predict the movement of wildfire smoke and dust storms. The version that we use in particular is called HighSplit. And we run this model backwards in time to tell us where air particles are likely to have come from. So I'll show this one example from January 1st, 2015. This is in the peak of Kawasaki disease season when you have many cases for Japan. This was a winter season where that year in particular saw a lot of Kawasaki disease. And just specifically, the Tokyo region saw 14 KD cases and 122 cases in that week. So what this video is going to show is if you take 100 particles and see backwards in time where they're likely to have come from. So they start closer to Japan, and then the farther backwards you go in time, 24 hours, 30, 40 hours backward in time, this model is showing that these particles likely came from over Northeast China, and the farther backwards in time, they originated from a wide region from China, Mongolia, and Russia. And so this is what we do for a single hour if we're looking at KD cases. What we're going to explain next, if you take all of those dots and draw a line for the whole path that they traveled backwards in time, that is this picture in the middle, where each line is the path of one particle that we're modeling. And if you go for multiple hours and days, you can see how these paths backwards in time change from day to day. So on some days, the origin of air is coming more from the north. Sometimes it shifts farther to the west. And in addition to direction and these kinds of spatial patterns, there are other information we can get, such as how fast the wind is blowing and how much it's mixing at sort of different levels in the atmosphere. So we've run this model for many days over decades across the record of incidents, and that creates estimates of sort of the average air, which we can use to compare with the typical season of Kawasaki disease, sort of the months you have many cases, the months when it's relatively rare. So this picture is showing a map of sort of the average January wind pattern for Tokyo, where the darkest red colors are areas where the wind is more likely to come from. Yellow is also likely, and the darkest blue is less likely. And where there are no colors, it's very, very unlikely that the wind you're breathing in Tokyo came from those areas. So this is a typical January. You're seeing a lot of air coming from the west and the northwest. And you can see how that changes over the year. In February and March, it gradually begins to shift away from the northwest, and kind of you're getting more air you're breathing is coming from the south or the east, going towards the low season when there's less KD in August and September. You have less air coming from the northwest. And as you shift towards fall and KD creases are increasing, you see a return of this pattern where the air in Tokyo is coming more from the west and the northwest, in sort of continental Asia. And that really helps us in comparing with the typical season of Kawasaki disease. So I'll talk about some of the new evidence that we're seeing for an actual association between the wind and Kawasaki disease in Japan. I'll explain this figure. On the top, this is showing for that sort of peak fall, winter, spring season, the average wind speed that we're getting from these modeled particles backwards in time. And these are during the months when generally the wind is coming from the west and from the northwest. On the bottom, this graph is showing, again, for those winter season, the total number of KD cases for a particular year in the patient category of 3 years and up, which we have evidence is more susceptible to some of these environmental associations. And if you think back to the general many-decade trend, you see that in a small slice here from 2010 to 2019, you have increasing cases. But aside from that year after year increase, particular from 2016 to 2017, there was a decline in cases that was very significant, especially in this older patient category, which then recovered, and you had an increase going from 2017 to 2018 until 2019. So looking at the country as a whole, it seems as if something funny is happening in 2016 and 2017, leading to fewer cases. So going back to the top, looking at the average wind speed in those months, the years in which you had relatively few cases, from our model, we do see slower wind speed. And extending this to some of the years with higher cases, it seems to be that the years with relatively many cases also saw faster wind speeds. So how do we think about that in terms of this overall wind theory? These are months when, again, the wind is coming from the west and northwest. So you're thinking about continental Asia as the source. And the way we interpret this so far is that we think faster wind speeds could lead to more KD-causing particles traveling from continental Asia to Japan, So potentially stronger winds leading to higher concentration of these trigger particles making their way to this country. So it's really a privilege to be working with this multidisciplinary team of doctors and climate scientists. Thank you. I hope this was helpful.
Great. Thank you so much, Charles, for taking us on a climate adventure here. And I'm sure there'll be a few questions in the chat about that, or in the Q&A rather. So shifting gears back to medicine and our patients, I'm going to turn it over to Angie Verdine Rodriguez, who is our coordinator for the adult KD study, and then Bradley Phelps, who is a adult KD patient who's going to share some of his story with us. So turning it over to you, Angie.
Hi, thank you so much. Okay, so my name is Angie. I'm the research coordinator for the adult KD study, and Dr. Burns had mentioned it earlier. So I'm gonna kind of zoom through this a little bit quickly, and if you have questions, send them in the chat, or at the end of the slide, I have my email that you can reach me at. But I do want to shout out the Gordon and Marilyn Macklin Foundation. Without their funding, this project really wouldn't be running anymore, so I'm very thankful for that. And this is what our adult KD team is made up of. So we have about 4 cardiologists, and then Dr. Burns and myself. So what is the adult KD study? It is basically a longitudinal questionnaire survey that allows us to really further understand the cardiovascular and general health of individuals who experience KD in childhood. And it gives us insights about the long-term outcomes for those KD patients. So as of October of this year, the total enrollment is about 763 participants in our study, with controls consisting of 193 participants. KD patients make up 570 of them. And cohort 1 are patients that were originally diagnosed and treated and followed at Rady Children's very closely. Those are about 306. And then cohort 2 are patients treated at other institutions around the country and around the world that reach out to us post their diagnosis. Now, what does the study involve? The study involves an online detailed health questionnaire, a follow-up health questionnaire every 2 years if you're not a control participant, and then an optional blood sample for subjects that are based in San Diego County who can participate. Now, we can have participants who had KD in childhood, so obviously those would be my cohort 1 and cohort 2 participants. And then I would have my control participants who are adults who've never had KD in childhood. We don't encourage or allow the enrollment of parents just because we do understand there is a genetic susceptibility to it. So we would encourage maybe an aunt, a grandparent, something of that extension, just not direct relatives. And I do want to encourage everyone that if you are interested or know of anyone who might be interested in joining the study, please email me at this email right here, adultkd@health.ucsd.edu. I can answer any questions in regards to the study. And then also our QR codes are here for our website and our Instagram. And then for Instagram, you could just also search up adult KD, and then we'll be the first ones to pop up. And so now I'm going to move it on quickly to Bradley so that he can give us more insight about what it's like to be an adult who had KD.
Thanks, Angie. Really appreciate it. And I want to say, extend thank you to Dr. Burns and the whole team here who do really, really important work for people like me and for having me on to talk about my story. And thank you for doing this study, which will be hugely informative for the people like me. So I'll start when I was young because I got Kawasaki's disease when I was 5. I grew up in upstate New York, being a very active kid, and then at 5 years old, my parents took me into the hospital, and it was determined I had Kawasaki's disease. I was in the hospital for about a week at that time. I don't remember a lot of it besides some really incredible nurses and doctors and others who engaged with me and came out of that experience with Kawasaki's disease, obviously, which I still have. And at that time, it was around 2001, 2002. Obviously my parents were very concerned, and we were doing everything we need to do, going to the hospital quite frequently to do various tests and whatnot. I was taking anticoagulants and aspirin. I was taking warfarin and Coumadin at the time. I've been taking it since. But all through my childhood, there was definitely an understanding that I was different, which sounds dramatic, but just different in the sense that I had something I needed to be aware of, and that was a heart condition, that had implications for me. And so what that meant was mostly that there were certain sports that some of my friends did that I wasn't going to do, like football and lacrosse and wrestling and some of these things. And I was okay with that. There was plenty of other sports I was interested in doing. And so I was very fortunate to be a very, very active kid when I was younger. And that was something that is, I think, part of the reason I'm still alive today. There were certain precautions that we took for some of those sports, like eventually in basketball, I started to wear a little bit of a protective headband to hopefully dampen any head blows that might happen in basketball. And in baseball, when I was in middle school and I was pitching, I had to wear a helmet and a face mask just in the rare event that a baseball gets hit back at the pitcher. Fortunately, that never happened. But when you're 13 or 14 years old, you may not have the confidence to put on a helmet and a face mask and feel great about it when you're doing team sports at that kind of age. And that's something that I credit, I give credit to my parents and my doctors about, which is still allowing me to play some of these sports I wanted to, like basketball and other things, but taking some precautions to keep it safer, but still allowing me to do that, right? My parents could have taken the perspective that we need to wrap you in bubble wrap and not even allow you to, play basketball or play baseball, but they didn't, and I'm very grateful for that. All growing up, I was doing stress tests instead of a bike at that you guys talked about. I was on a treadmill that would increase in its steepness and work to get my heart rate up. And so we were doing everything we needed to. I was in all these stress tests because I was a really active kid. I performed just fine. I did really well. And as I got older, into high school, I was a runner in the fall in the spring and played basketball in the winter. So I was really stressing my cardiovascular system quite a bit. And so I was in great shape. And when I went to college, some of those follow-ups started to slip in frequency. My life changed, obviously, in the sense of my exercise regimes changed and often were less in college than they were in high school. And it would maybe be more frequent that I would forget to take my pills in the morning, take my medication, these sorts of things. And that was even more exacerbated when I left college, where I was still pretty active and moved to New Jersey, where I took a job after my undergraduate degree. And at that time, it was a desk job. And that's something that I would say to all folks who have KD, which is like that sedentary lifestyle piece that Dr. Doomer was talking about earlier is you have to be really cognizant of, and something I try and be really cognizant of now. But anyway, I was living in New Jersey. I was trying to figure out a way to make friends in this new place where I didn't really know anybody. And so I joined an intramural soccer league thinking it's an adult intramural soccer league. It's not going to be that serious. So I can just avoid heading the ball, which I knew wouldn't be healthy for me. And what ended up happening in my first soccer game is what has been told to me. I don't remember any of this, but is that I basically collapsed. I had a heart attack that turned into cardiac arrest. EMTs showed up. They shocked my heart back to life. Some people told me it was 2 shocks. Some people told me it was 4. I was rushed to the hospital. at some point I was put into a medically induced coma, and partially because of the complications with my heart, I was moved to a larger hospital in New York City, where I was very fortunate to receive great care, and I was had they treated me with some type of medical induced like hypothermia to try and prevent further brain damage. And so after this event, there was a news story written about it. If you Google my name, Brad Phelps Today Show, you'll find it. But what they say is that my heart is stopped for 12 minutes. That seems unlikely statistically, that I would still be alive after that. But point being that during that time, they were worried about, all that time without oxygen, that there's severe brain damage. And so that's why they did the induced hypothermia. But anyway, I was in that hospital in New York City recovering. They put an implantable cardioverter defibrillator in my chest, which I kind of haphazardly call like a backup generator for my heart. The idea being that, God forbid, if something were to happen again, it would defibrillate the way the EMTs did for me on that day in October of 2019. Was released from the hospital in mid-November of 2019 and started to recover, started to learn more about my disease, and started to think very differently about my health after that. When I was thinking about this talk and thinking about how to frame it, I think what the core lesson learned here is that we weren't, by we I mean me, my parents, my doctors in general, we weren't skeptical enough of my heart health, because I kept getting stress tests that were healthy. I kept getting stress tests and other tests that made my heart look good. And as the frequency of visits and checkups slipped, that coincided with changes in lifestyle and otherwise that led to a blockage in my heart that caused my heart to trip, and I had a heart attack. And so as a result, because of a lack of skepticism, something very, very scary happened. At the time, I was, fresh out of college, living even further away from home, like I said, in New Jersey, and my parents were living 3 hours away and had to get a call from a police officer who couldn't tell them a lot of details of what happened due to HIPAA laws, just that their child was in the hospital in the middle of the night. It was around 11 p.m. And so it turned into a very scary situation for everybody. I don't remember any of this, so a lot of this is old to me, but I was very fortunate to receive care from hospital in New York City. And like I said, now I think very differently about my health. I have a different diet now. I try and be more cognizant of my exercise, which I'm still not getting enough of intense or moderate exercise, but I bike to work every day now. I have a kind of desk related job, but I have a standing desk, and I try and get up and walk away from my desk even every half an hour if I can. And so, to people like me, to other young adults who have this disease, just realize that 10 positive stress tests in a row doesn't necessarily mean that in the next 2 years, your heart is going to be perfectly fine, right? And I don't say that as a means to scare folks, but just as a means to say we should be skeptical of our health even when we're healthy, which sounds a little backwards, but I guess I'll leave my story there for now. If anybody has any questions or would like to follow up with me or know more details about it, I'm happy to share it. But again, very, very grateful to Dr. Burns and everyone else here for having me on to share this and for the really, really important work that you all do. So thank you.
So Bradley, thanks so much for taking the time on your Saturday to share your story with people. And I'm sure it's very impactful, just so everyone understands Bradley had giant aneurysms at the time of his initial Kawasaki disease. So this is not a story for patients who have normal echoes. This is a story about the follow-up and the surveillance and the staying on top of it that's involved when your child has giant aneurysms. And I think this transition from teenagehood, where you've got your parents watching over you, to young adulthood is this very, very vulnerable period. And I think as medical providers, we're all needing help and understanding from people like you, Bradley, and others. How can we make sure that this doesn't happen to other young adults who, it's a period of time in your life when you feel invulnerable, you feel otherwise healthy and things are going well, and people keep on telling you and reinforcing that by saying, gosh, your stress test was great. And it's yes, but kind of. That's a fine line to thread. And I'm sorry that it didn't happen so well for you, but I hope that you'll stay involved with adult Kawasaki disease patients and do your own helping for people to tune in to what's needed. There's also a whole new conversation about systemic anticoagulation. So Bradley, you were taking warfarin, and we're really fortunate now that there's a new generation of medications that I think is ultimately going to replace warfarin and already has in many parts of the country, and is going to be a more reliable drug and anticoagulant, and also kind of gets around this invincible young adult, I don't need to go and have my blood checked. You still need to take the medication. That's those pills don't work unless they go inside your body. So it's a complicated thing for, I think, any chronic condition, whether it's Kawasaki disease or diabetes or a million other conditions. It's a period in life that's just very tricky. So thank you so much for sharing your story. We really appreciate it. So it's time now for our last Q&A period. I just wanted to end with one thought, which I will share here for a second. And that is really a call to action. So all of the work that we've been talking about today is funded by either research grants or by philanthropic donations. And recently it's been more philanthropic donations than research grants. It's a very tight market right now in the research funding world. And Dr. Tremolay, myself, and others on our team are all very active in trying to raise the money. But if anyone on this symposium or participating in this event has the interest in learning more about how you can help us, Amy Weeks is our amazing Senior Development Officer at the Rady Children's Hospital Foundation. I can share with you that she's also a KD parent. But she's a wonderful resource for our team. We wouldn't be here without her. And if you'd like to find out more about donating or how you can participate in fundraising for the research on Kawasaki disease, here's her email address, and she is very happy to hear from you. So with that, I will stop sharing and turn it over to Audrey to moderate the Q&A session.
Yes, so thank you to everybody that presented in our second session, especially to Bradley for being with us today and sharing your story. I want to also just give a shout out, as Dr. Burns did from the very beginning, to the KD Foundation, without whom this wouldn't be possible. So this is being recorded, will be available to others that have not been able to join us this morning live for the as a recording. So we look forward to spreading the news about it. And the other person to really give a big shout out is to Jennifer Kim, who's usually functions as our database manager, but today is IT extraordinaire. And she really, got us all onto this webinar, got it all coordinated. So thank you, Jennifer, for keeping us all on task and making it possible. So with that, we're going to go ahead and get to some questions. And I wanted to start out for Dr. Burns about the adult KD study, just some lessons learned. So there's some questions that have come in the chat. There's also some that came to us initially earlier by email that have to do with the association between KD and other diseases. For example, there's questions about whether KD is associated with postural orthostatic tachycardia syndrome, which is POTS, or whether it's associated with seizures or with, feeling faint and dizziness and joint symptoms. So, as we all grow up, we get a lot more aches and pains, as we all know. And what have we learned from the KD study about what's associated with Kawasaki disease?
So a preliminary look at the data that was published last year raised the question of whether migraine headaches might be associated with adults not present in childhood, but something that develops later in their life. And there was a suggestion that it might be happening more often in our Kawasaki disease patients than in our age-similar young adults who never had KD. We're getting ready to reanalyze the data, but it's why we're doing the study and why we need bigger numbers so we can really have robust information about that. So stay tuned, and thank you to everybody who's participated. The POTS question, this orthostatic hypotension question, it often is directed to our cardiologists, but it's actually not a cardiovascular problem. It's actually a problem of the neurologic part of our bodies called the autonomic nervous system. We don't have a specialist at Rady Children's Hospital for this problem, and yet we hear a lot of teenagers with this complaint. There's no reason to think that it's directly related to Kawasaki disease, but it does seem to be a problem affecting a lot of young people, not so much in childhood, early childhood, but in this teenage population. And there are specialists who are autonomic nervous system specialists. We don't happen to have one at Rady Children's Hospital, but it's not primarily a cardiac problem, and no evidence right now that it's directly or even indirectly linked to Kawasaki disease.
There's several questions that had come in about the use of statins, and we didn't get to that this time around. We talked about it last year, and Dr. Shimizu from our team gave a great presentation at the International KD Symposium. Just to let everybody know that the work that that we've led with doing studies of children with aneurysms with statins is that it can be used, the atorvastatin specifically is what we tested, can be used in children 2 and above, that it's safe. And we do have patients that develop giant aneurysms that we put on atorvastatin for a longer period of time. That's a study that Dr. Miyata has been doing with us. So there is a rationale for really helping that lining of the vessel wall, those endothelial cells, to heal. And that's what the statins do well. So just to remind everybody about when the statins can be used. There was a question.
I might add to that I would really encourage all the parents whose children have persistent aneurysms to talk with your cardiologist about that. It's kind of a new thing, and there are a number of publications out there from Dr. Tremblay in a clinical trial for younger children, and then work more on the science side from our team. But there is information out there about why you would use a statin, not for lowering cholesterol. That's not the issue, but it's really about increasing the health of the blood vessel.
So Dr. Burns, there was a question about the risk, if any, that low-dose aspirin may take with Rice syndrome. and about the flu vaccine, and whether you should get that prior to discharge from the hospital.
So no and yes. There is no danger at all with low dose aspirin and Reye syndrome. I trained at Boston Children's Hospital where we kept the National Registry of Reye syndrome. It was a terrible disease, and it occurs in the setting of two viruses. One is influenza virus, the other one is varicella virus. And it occurred with the doses of aspirin that we do use in the hospital in many centers. It's the dose that controls fever. It's not the very low dose aspirin that your child will be sent home on. The flu vaccine that's given with a shot is killed. It's not a live virus. And there's no concern at all about any interaction with low dose aspirin and the vaccine. And yes, everybody should get the flu vaccine because it's a really terrible infection. And you want to protect yourself as much as you can. And certainly if you just had Kawasaki disease, you'd like to be protected. There probably is some protection from the IVIG as well.
So the next question is about follow-up, which we've been addressing. And there's, we've got families from around the globe. We've also got a family that typed in, it's a military family that's moved. So at the last checkup with a cardiologist that she had arranged for her in another city, she was asked by her cardiologist, "Why are you here? Your heart's fine." Her child is 9 and had had KD at the age of 2. So I thought we'd just take a minute to sort of address the long-term follow-up, because I think we do it a little bit more long-term here at Rady Children's than a lot of other places do. And there's, a need for that in some cases. In some cases, we just love to keep our families around and educate them more about KD. So maybe you can just start out, Dr. Burns, by addressing the long-term follow-up and what's typical, and then there's another question in their answer that I'll get to as well.
So everything with the long-term follow-up really has to do with the community that you live in and the resources that are available. So at our Center for Children who never had an abnormal echo, we see them back. So these are normal people, okay? Normal echo, always normal echo. And we do an echo in the hospital and we do an echo at a 2-week visit. And if those are both normal, our current procedure is not to repeat the echo because there isn't going to suddenly show something magical that we missed in the past. So this has been an evolving practice. We used to do more echoes, but now that we're really confident that we don't need to, we've stopped doing that. We stopped recommending that. But we do see the kids back roughly a year later. And at that point, we have an opportunity to do heart healthy counseling. So this is what I talked about, the other kind of heart disease where there are modifiable risk factors. And we want to empower families to try to have the best heart healthy lifestyle for their children. This could easily be done by a pediatrician, okay, or a clinic, or a health educator or someone like that. But in our community, that doesn't seem to happen. So we've taken over that role in our Kawasaki disease clinic. So we see the kids back at 1 year when we do the lipid panel. They've now fully recovered from inflammation. They're at their baseline, and that's what we want is a baseline study. And then we discuss those results with the parents so they understand what the results showed. We see them then 5 years later for a heart healthy discussion, checking in about exercise, promoting exercise, and other aspects of heart healthy lifestyle. And then we want to see the kids back at when they're teenagers. So we start at age 15 and up before they graduate from high school. And that's the session where we have a sheet that we fill out for them. They were, most of them, too young to remember anything about their Kawasaki disease in infancy. We want them to understand their medical history. And so we give them a sheet that we fill out together that has what were the results of their echo. It has their lipid panel results, their blood pressure, their percentile of height and weight, and any other findings from the echo that we think they need to know about. And we ask them to we fill that out together. We ask them to photograph that on their phone so they have it with them. And that's an important source of their health history as they go forward in life. Now, obviously, the discussion is very different for our patients such as Bradley, who have giant aneurysms. And we have a whole program of transition of care that Dr. Tremblay has created. We'd be happy to share it with other centers around the country. It's an online questionnaire, basically a test that our kids starting at about age 12, if they have even remodeled aneurysms, we need to make sure they understand that they need follow-up. And had that been done in Bradley's case, could that have avoided a catastrophe? I mean, we can't rewrite that history book, but that's certainly what we're trying to avoid. We're trying to really make sure that children, as they go through those teenage years, understand the importance of the follow-up that they're getting, the importance of their medications, how to refill a prescription, you know, a lot of health maintenance stuff that they have to do that's not normal, that not all children have to do. And we really want to make sure that we're doing the best that we can do to train them to be their own health advocates. And there's also, of course, the genetic counseling piece. So for our kids who have completely normal hearts, and we've just been doing heart healthy counseling, for those kids, we just want to explain the genetics so that we don't repeat the scenario of a parent coming into our emergency room. We diagnose the child with their baby with Kawasaki disease, and they go, "Oh my God, you're not going to believe this, but I had Kawasaki disease when I was young." And that shouldn't happen. We want everyone to understand that this is fundamentally a genetic condition.
And there was a question about whether IKDS.org is the place for physicians to go and learn about KD. We certainly hope it will become that. I will tell you that we were so busy planning the meeting that it hasn't yet been built out too much, but that is the goal there, is to have that as a central repository for all to learn. And sort of, you know, if you land on that page, because we all know how Google works, you type something in, you only look at the first page of your results. So if IKDS.org happens to populate, then it'll be a great branch point to get out to other areas. So we do hope that that'll be a resource for both families and for physicians alike. There's a few questions about the environmental work as well that I thought you could address, Dr. Burns, or to have Charles add as well. So there's a couple questions. One is, are there any ideas about antigens, either environmental or infectious, based on the wind studies that have been done in terms of triggers for KD?
Start with that. We're still investigating multiple antigens. So the story of increased wind speed leading to potentially years when you have more Kawasaki disease could fit potentially with such an air pollution story. We're sort of either, you know, urban air pollution or air pollution associated with industrial production in sort of continental Asia and China, increasing over many decades. That is one thing we're really interested in looking at, particularly looking into going from this long distance wind modeling to local measurements of heavy metals. But we're still investigating sort of these multiple hypotheses.
And is there, is the implication that the wind velocity is associated with higher incidence of KD in sort of the Asia Pacific region or the Americas and Europe?
So within the Asia Pacific region, I think one useful next step would be to see if we see similar trends in South Korea, where we also see relatively high incidence of Kawasaki disease, and you'd expect similar trends. That will be a future research direction. Probably too early to say whether it's the same trend happening in the Americas or Europe. But I think the lessons we learned from Japan are going to be really useful to try to uncover the puzzle for what's happening in other regions.
I think I could add to that there is a thought in climatology that the speed of the wind may correspond to the amount of aerosol that it carries and the exposure of people breathing on the ground. So there is that kind of link, or that thought about that link.
So Dr. Burns, can you share a little bit about the importance of a calcium score for KD patients, someone who's now a young adult? Why is this important? How often should it be done?
So a calcium score is a screening test that uses a CT scanner, but it is not a CT scan. That's an important differentiation. So a calcium score doesn't involve an IV or any dye injection. It's simply looking for calcium deposited in the wall of the coronary artery in the form of a scar. And we have been recommending this for all young adults who do not have a very precise understanding or knowledge about the nature of the echocardiograms that they had maybe back in the 1980s or 1990s. The echocardiograms from that period of time were really not as sensitive as the machines and the transducers that we have available today. So they weren't great, and a lot of things got missed. The calcium score would only be positive in someone who had actually had aneurysms. So it doesn't rule out that you had Kawasaki disease, but a calcium score in a young adult should be 0. And if it's not 0, then you need a cardiologist and you need more investigation to understand why it's not 0. So it's been a great screening test, and I have to say, we're aware of many young adults across the United States who really had a fuzzy concept of whether there was anything wrong with their heart at all after Kawasaki disease, and a very positive calcium score. It's about $100 out of pocket in most communities, easy to get ordered by your PCP. And it really saved their lives because they had important coronary artery changes that were completely silent, that they didn't know about, and now they're on the right track with medications and testing to keep them safe. So we highly, highly recommend it for all young adults who are uncertain about their history of Kawasaki disease. It only needs to be done once. It should be at least 10 years after you had Kawasaki disease, because it takes a while for the scars to form. But mostly this is appropriate for people now in their 20s and 30s who may not know details about their history, or older individuals who had Kawasaki disease but are not clear about how their heart's doing. Please get a calcium score. It's a really great test.
Yeah, and we've used this in some of our families where, there's a child that's affected and the grandparent will say, oh, my child had this, and that's like the mom or dad of the affected child that we're seeing in clinic. And so, oh, you were sick when you were 5 and you were diagnosed with one disease or the other or nothing, and then we're in the hospital for a long time. So our recommendation for those, we don't know if they had KD, if there's a compatible history, we'll suggest that they contact their provider or do it out of pocket and get a calcium score for those adults. Yeah, it's a great screening test for that. There's a number of questions about the statins, as you can, we'll get back to this next year, I think, too, and there's always a lot that to be discussed. So there's a question about, is there any reason not to put your kid on a statin? So I'll just address that quickly with our current recommendation for children with Kawasaki disease, and again, not related to cholesterol, because we don't actually want to drop anybody's cholesterol, is for children with aneurysms, and especially those with giant aneurysms, because that vessel wall is injured, and because we know that the statins work with healing that area. That's the child that we work on putting on for the statins. So I know that there's maybe some confusion in that arena, but for children that have always had normal coronary arteries, those that have very transient swelling that goes away, we would not put those children on statins. Let's see here. I think we're coming up to the end of the hour, or the end of our time together. One last question that came up was just about patients with aneurysms, and what type of jobs are they eligible and could have? Thought that was an interesting question, kind of following up on Bradley's, conversation about things. And so, what types of jobs should patients with Kawasaki disease who may have giant aneurysms be working in? What kind of field are folks able to work in? So, Brad, I'll let you chime in maybe a little bit with your line of work and leaving us with some final ideas.
Sure. Yeah. Yeah, it is an interesting question. Well, one, I think just being aware that I guess jobs where there's an increased risk of bleeding is probably not a great idea if you're on blood thinners. Like I said, the work I do now is I'm a research associate at University of Maryland, kind of doing energy policy and other policy related work in environmental policy. So I appreciated Dr. Copeland's presentation earlier. But yeah, I think, the other thing to keep in mind is jobs maybe that provide chronic stress might not go nicely with the intrinsic stress that's already on your heart. If you have giant aneurysms, that's some pseudoscientific advice right there. But just the idea that realizing that KD maybe is kind of an extra risk that if you're putting in other risks with your job aren't going to lead to the best solution. So like I said, because I have a desk job, I have a standing desk. I get away from my desk pretty frequently. I bike to work instead of just, getting in my car to drive to work, then go sit at my desk, these sorts of things, right? So realizing that small things like that of literally getting yourself out of a seat frequently is really great for your heart, even if you don't have KD. And trying to really incorporate that into your life broadly, I think can be helpful. So I'll leave it there.
Thank you. And with that, we'll all soon get out of our seats too today. So I will go ahead and Dr. Burns, give you the chance to close up our session today. I just want to thank everybody from around the globe for your time and spending your Saturday, whether it's morning or evening for you, with us. And we're greatly appreciative of our entire KD community. So Dr. Burns?
Just a shout out to everyone on the panel who participated, to Jennifer Kim for making it all happen, and Gary Lyash in our department, who also was able to get everything going. A shout out to the KD Foundation for sponsoring this event every year. And to all of our families who believe and trust in us and have participated in our research, have donated your child's blood, have given us your DNA. None of this research happens without a community of patients who believe that research is the way forward to get better answers and have a better life for all of our children. So a heartfelt thank you to everyone. Dr. Tremblay, Dr. Doomer, and myself are always available by email to physicians, to families, to all kinds of people around the world. And we're always here and happy to hear from you. So thank you so much.